Hello, my name is Lisa Wynne. I'm the Parkinson's nurse specialist with the Parkinson's Association. And this evening we wanted to talk about the menopause and Parkinson's disease. So myself and Richelle Flanagan are the two speakers tonight. And if you have any questions, you can contact ourselves through the PAI support line or by email. So by no means am I an expert in the menopause, but it was actually really interesting doing all the research for this presentation. And just to give you an idea as to why we're talking about it. So I was approached by YPI a couple of months ago now to see would I give a quick talk about the menopause. And it was really because the Davina McCall program was on. Where she was discussing the menopause. And recently there's been a huge amount in the media about menopause, including Lidl, who have a new policy in supporting menopause and increasing awareness for employees. There is the development of the Menopause Hub and then government policies as well. But for I suppose women with Parkinson's, well, there's kind of a circle of a taboo. Women's health is not really talked about, be it from menstruation all the way up to menopause or postpartum issues. Mental health is also another area that we don't talk about often enough. And then with Parkinson's, well, young women, why would young women be people who suffer with Parkinson's? Because there's the myth that it's a disease of the old man. So there's three circles intertwined where we don't talk about it at all. So I think it's really good to actually speak about it, especially women's health. And then for YPI with Parkinson's, obviously it's great to be able to talk about it and to give it an explanation into it. As I said, I've learned a lot from doing the research, so hopefully you'll learn a little bit more. I'm just going to touch about the menstrual cycle because I know that Richelle is going to talk about it a little bit. And it's just, I suppose, to point out that I know it was pointed out to me plenty of times that when women were going through their menstrual cycle, usually the week before, along with VMS, they would always have increased symptoms of Parkinson's. And they found it very hard for consultants to get their head around it, to agree with them, but found, and I know one person in particular found it really beneficial to increase her medication temporarily, just for the week before her menstrual cycle started, and her symptoms then improved. So it may be a case that a slight temporary medication adjustment is needed. Obviously, always speak to the physician or the neurologist that's prescribing the medication. But if you could keep track for a couple of months so that you would have it there written down for the neurologist when you do go back to see them. But I know Richelle is going to talk a little bit more about it later on. So for Parkinson's disease and the menopause, well, Parkinson's disease is more common in postmenopausal women. And Parkinson's disease affects approximately 50% of women. So at some stage through our life, we will all go through this as women. And some people will go through it in the earlier stages, as the early onset menopause or early menopause. And then there's always the, I suppose, blurred lines of, are they Parkinson's disease symptoms or are they menopausal symptoms? And I've spoken to a few people who would have been diagnosed postmenopausal, but they would have had all the symptoms for a long time, and it was just put down to the menopause, never thought of that it could possibly be Parkinson's. So the menopause itself, it usually starts between the ages of 40 to 55 years of age. That's the normal, I suppose, but as I said, there may be the early onset or the premature menopause. And it's the change in the cycle. And it is the perimenopause versus menopause. So what a perimenopause is the natural period of change or transition. So that's where they get the term, the change. So it's a natural period which begins several years before the menopause itself. And it can last from a few months up to 10 years for some people before the actual menopause itself. And you may see changes in your cycle. So it might be every second month, or it might be lighter. And then menopause itself is the stage when the ovaries completely stop producing your reproductive hormones, and there's no monthly periods for consecutive 12 months for a full year. With regards to the hormones, so I suppose we all hear, and even it kind of brought it back to me as to what these hormones do. But what are these hormones that we lose responsible for? Well, estrogen and progesterone are the main ones that decrease. And estrogen is produced by the ovaries. It's responsible for the egg release. It's responsible for the production of bone cells. It's also responsible for the stimulation of smooth muscle. So that's for your heart, for good heart health, and prevent heart disease, and for smooth muscle for your gut as well. And it's responsible for collagen production. So for your skin, your hair, and nail health as well. And also it has a role in cognitive function. So you'll see where I link all of it back in a few minutes. But with regards to progesterone then, so this hormone itself is released after ovulation, and its main role is within pregnancy. So it's preparation stage, maintenance, support of pregnancy. They call it the nurturing hormone. So it does have an effect on our mood, our nervous system, and our ability to relax, or level of anxiety as well. So the symptoms of menopause. So the first 5 that I have listed here are usually the first symptoms that may be experienced. Sleep issues, psychological issues, so that might be anxiety, increased anxiety. Lower fluctuating mood might also be experienced, and low energy levels or fatigue, and possibly headaches. So they're usually the first 5 symptoms that people will experience. Further symptoms then are skin changes. So because of a declining collagen level, skin changes can occur. So you lose your firmness, and the skin can also thin. And then obviously if it's collagen levels are decreasing, then it can also cause pelvic floor issues, so pelvic floor dysfunction, which can lead to bladder weakness and bowel weakness, but I'll go into that shortly. So more symptoms then continued, because it doesn't stop with just one slide. So night sweats may be experienced, hot flushes may be experienced, restless legs, muscle pain, decreased secretions, which can lead to a decreased libido, and then can lead to an increase in urinary tract infections. And your gut motility changes as well as you go through menopause. So when you go through the list of the 2 of those, you wonder, I mean, before I went in to do my research really about the menopause for tonight, I would hear an awful lot of those symptoms of Parkinson's. So is it Parkinson's symptoms, or are they menopause symptoms, or are you getting hit from 2 directions? And just to speak briefly about, I suppose, the considerations that you might take, the supplements or stuff like that, and also the hormone replacement therapy. So HRT, which we'd heard about, and it's also why it's in the media, because in recent months there has been a severe shortage of HRT in Ireland and in Europe. And some people are quite, I suppose, it's a fear mongering that I suppose people are fearful of hormone replacement therapy, but it may be a necessity. And it's really about educating people as to what this hormone replacement therapy does. So there are 2 main hormones used in HRT, estrogen and progesterone. And most women will take a combination of both estrogen and progesterone. In Ireland, testosterone is off license, but it can be used, and it is used in some countries. But estrogen will always be the one that is used in the hormone replacement therapy. And most, I suppose, women who no longer have a womb, so have had a hysterectomy, can take estrogen alone, which is important. Estrogen and progesterone together, or plus or minus testosterone. So it just depends, but in Ireland, the testosterone isn't licensed yet. Hormone replacement therapy is not just tablets. It can come in gel form, cream form, pessaries, rings and patches. So there's a variation of administration. And as I said, the increased demand or the increased shortage is likely due to an increased demand because of an increased awareness of HRT. So the word has been getting out there about the importance of replacing the hormones that are decreasing, and therefore the demand has increased. And we have, I suppose, not an aging population, but we are all getting older and becoming more aware, and women's health is becoming a more priority and is getting more media coverage. So maybe that is another reason for us to be in the media, increasing awareness, and then the demand increasing. And then, of course, there's the issue of the price of it, and is it covered on a medical card, which Richelle might be able to answer, but I couldn't really find a huge amount of information about it. If you are on HRT, if you are thinking about HRT, always speak to your GP or your physician or your pharmacist, because they're usually an abundance of knowledge. Other considerations then, I suppose, that I came across, well, obviously diet, and that's where Richelle might come in. Vitamin D, which people with Parkinson's are known to be deficient in. Vitamin B6, which is your hormone regulating vitamin. B12 is responsible for your energy levels. Biotin then is responsible for hair health, and omega-3 then, as we know, is responsible for heart and brain health. There was also a suggestion of sage drops or sage tablets for night sweats, which the researchers say that actually the drops work quicker, so sometimes they're more beneficial. Exercise obviously comes into every single aspect of every talk that I give. The benefits of exercise, the importance of it to not only help with the physical aspect of Parkinson's, but also to help with the psychological and serotonin production. And look, there are supplements out there for every type of skin issue that you may have. There are supplements out there for post-menopause and perimenopause, but it's really up to yourself as to whether you wanted to try them, if you feel they'll be beneficial. And obviously I can't recommend one over the other, but I know some of them even have collagen supplements and stuff like that. So if you try them and you find them beneficial, then great. But I haven't, so I can't recommend any. Just to discuss pelvic floor dysfunction, because it's something that is becoming a lot more publicized. And even from having my first child to my second child, the change in the education around pelvic floor was huge. So they are finally realizing that pelvic floor dysfunction is a very common issue, both postpartum, so after childbirth, postmenopausal as well because of the hormonal changes. Also with those who suffer from chronic constipation. So obviously people with Parkinson's are more likely to suffer with constipation and chronic constipation specifically. And there's research out there. So some people say that 1 in 3 women experience urinary incontinence. Others would say 1 in 1 at some stage through your life will suffer from urinary incontinence. It also may be bowel incontinence as well. It's not just urinary. But the whole idea of the pelvic floor is that it is your hammock, it is your support, and it's a group of muscles that wrap around between the bladder and the rectum and hold everything in place and support it. And it allows normal filling, normal storing, and normal emptying of both your bowel and your bladder, and allows control function. So it allows you to maintain control over your bowel and your bladder. And postmenopausal, the reason I speak about it is because there's a change in collagen, which leads to a decrease in firmness in not just skin that you can see, facial, or it's also the muscular, including the pelvic floor, because of hormonal changes as well. So I talk about it because there is more awareness recently and much more publicized women's health physios. I have spoken to a few people that have attended women's health physios who specialize in pelvic floor dysfunction. And it's a physical exam. You may require procedures if it's a prolapse or anything like that, that's causing the issue. But usually pelvic floor exercises are really, really good, and they do work. There are new things, and I don't know whether they work, I've never used them, but there's the chairs for pelvic floor exercises. So they use electromagnetic pulses where you sit down and it works on the pelvic floor. And I suppose there's online classes for pelvic floor exercises, and then there's specific physio-led women's health exercise classes for pelvic floor, or Kegel exercises, which is the other word for them. And with regards to the pelvic floor exercises, I mean, at some stage we'll all have been told to try and do them. Whether you do them or not is another question, I suppose, or how long you actually do them for. But the NICE guidelines are actually there in 2019 and updated in 2021, explaining that pelvic floor dysfunction and pelvic floor exercises should actually be taught in secondary school age. So they are finally realizing the importance of it, because it can have a huge effect on your physical and psychological well-being. If you are suffering from weak pelvic floor or incontinence, and it does stop you from exercising, it may stop you even from leaving the house, depending on the severity of it. But the pelvic floor exercises themselves, they take a couple of minutes, a couple of times a day. You can sit, you can stand, you can lie when you're doing them. And it's all about contracting and releasing the pelvic floor muscle. So controlling the bladder, which is a huge muscle itself, and also the bowel. And it's very discreet. I remember somebody telling me you could do it standing at the bus stop and nobody would know. And it's true. You can't really do them wrong. And I spoke to someone the other day who said that they were told that they didn't really believe, the consultant didn't believe in pelvic floor exercises. But if it's not going to do you any harm, and it is proven to be very effective, well then if it's going to take a few minutes out of your day, it's something that we all need to do. Be it postpartum or postmenopause. So there's a change needed, and I know Richelle's going to talk more about this, but we need to change personal awareness, so amongst ourselves, and try and educate ourselves a little bit more. I know I certainly have after doing this evening. We need to increase public awareness, so they are slowly turning. I suppose we need more highlight put on the issue with media, with documentaries like the one that Davina McCall did, but we also need workplace policies to come into action, including Lidl, who are steps ahead in many ways compared to other companies, and the recognition that menopause isn't just something that you should go through silently. But that needs to be all backed up by government mandates and government policies as well, and the recognition from the government. So in regard to the government, so there was the Women's Health Action Plan 2022-2023, where it has changed, I suppose, and with the help of media, it has put the spotlight on menopause for women. And I know certainly in the last 3 years, you hear a lot more about the menopause. So the Women's Health Action Plan, what it is that the government realised the importance of women's health, and they are developing 4 specialist menopause clinics nationally in 2022. So that's in addition to 2 further menopause clinics. So that'll be 6 nationwide. It's not a huge amount, but it's better than 1 or 2. And they hope that in 2022, there will be further specialist care for the more complex cases in Limerick, Galway and Cork. And there is one in Dublin already. And it'll be a multidisciplinary approach. So there will be consultants, there will be nursing staff, and there will be physiotherapists. And I'd hope that there would be dietitians. And then continence nurses should be also in there as well. For the more complex cases, just to bring everything in under one umbrella. So just a little bit more. So this itself is the Women's Action Plan. So listen, invest and deliver. And it wasn't just about menopause. It was about childbearing women. It was about the maternity hospitals as well. But it's good to see it. It's probably a long time coming. Just some extra reading. So there is NICE guidelines for pelvic floor. There is also guidelines for urinary incontinence and pelvic prolapse in women, and the management of it. And also the Women's Health Initiative in 2002, which I found when I was looking for information about HRT. So there was an editorial from an American study that was published in the Journal of the American Medical Association. And it suggested that there was a link between the use of HRT and breast cancer. And I know that this stood out back when it was released, or through the years, that I've always thought there was a link between it. And the study was called the Women's Health Initiative, commissioned by the US government, and they wanted to see what factors affected heart disease and cancer. So the ladies that were included in the study were all mostly over the age of 55, early 60s, and it was a randomized control, and the study did not suggest or prove that HRT actually caused breast cancers, but that there was a slight chance or slight association that in older women over time that red flags were raised and concerns were raised, and they should err on the side of caution. But actually it was unfounded, and it did scare a lot of people. So since then, they've realized that HRT can be prescribed. It should be appropriate according to each person, should be assessed. And that you should have the choice whether you want to use HRT or not, because some people suffer through very troublesome menopause symptoms, even without having Parkinson's. And it's not addressed because a lot of doctors were very concerned after this study came out about prescribing HRT. In fact, in Ireland, I think they stopped prescribing it altogether for a certain period of time. So the NICE guidelines point out that most people who need HRT are younger women, and that they're probably only going to stay on the HRT treatment for a couple of years. And together with the NICE guidelines and the Women's Health Initiative, it slowly brought about a change in the prescribing of HRT, which is a positive thing. Again, it's a personal choice, and it doesn't always work for everybody, especially if you have the question over, are the symptoms Parkinson's related or are they menopause related? And that is it. So I just found a few websites that I just wanted to mention. So Women's Parkinson's Project, Complex Menopause Service, which is through the National Maternity Hospital in Holles Street, and the Menopause Hub, which is a clinic in Mount Merrion, I think, in Dublin, that specialises in the menopause, the NICE guidelines, as I've mentioned, and there is a 2022 update due, and then menopause.ie as well. And that's it.
Yeah, so there's going to be a bit of overlap between our two talks, but basically, yeah, mine's entitled The Unmet Needs of Women with Parkinson's. And I suppose just in terms of, again, I suppose reiterating around the sort of symptoms and that, you probably all remember the good old days of PMS and, you know, all of the symptoms that came with that, you know, from swelling of their feet to headaches to depression, anxiety, mood swings, acne, food cravings, and the whole gamut. And actually in PMS, I think there's 130 or 150 different symptoms of PMS, believe it or not. And also there's a thing called premenstrual dysphoric disorder. So there's a percentage of women with PMS who have really kind of really harsh symptoms. So they have to, at least 5 of the following symptoms should be experienced during most cycles over the past 12 months to get a diagnosis of PMDD. So depressed mood, anxiety, tension, affective lability. So that's sort of, you know, crying, anger, irritability, decreased interest in usual activities, difficulty in concentrating, lack of energy, fatigue, change in appetite, food cravings, change in sleep, hypersomnia or insomnia, feeling overwhelmed or out of control, feeling discomforts in terms of joint pains, headaches, etc. And obviously PMDD also, it interferes markedly with usual activities, work, school, social relationships. And, you know, so you can see a lot of those symptoms, like show you here in terms of the iceberg of Parkinson's, that a lot of them are very similar. So I suppose in terms of Lisa's point about, you know, people being dismissed around their symptoms, you know, it's probably partly because it is difficult to discern between the symptoms are very, very alike. And I suppose what causes that? So it's to do with the hormonal fluctuations through one's menstrual cycle. So basically, in terms of estrogen, it drops just before your period, and then it builds back up, and then it drops again in sort of towards the week 3 of your cycle, and then it sort of comes back up again. So this is actually what causes a lot of the symptoms, are those fluctuations in the estrogen, but also the change in the progesterone as well. In fact, I was only just reading some study papers today about the impact on progesterone on anxiety. So that is actually, you know, a phenomenon in terms of the menstrual cycle. So I'm just going to bring you through now a survey. So I noticed myself when I was diagnosed with young onset that I noticed my Parkinson's symptoms got worse the week before my menstrual cycle. And then as I went into the kind of perimenopause phase, I noticed that my sort of cycle was all over the shop and my symptoms tended to kind of fluctuate a lot. And I noticed from a lot of other women living with Parkinson's that they were mentioning the same issues. So I put together a survey and surveyed women about their hormones and the impact on them. So just summarizing here, we asked whether the Parkinson's symptoms worsened around the menstrual period, and you'll see that there was a high percentage, just over 70% said yes. Which motor symptoms got worse, and you'll see here it tended to be bradykinesia, rigidity, tremor, and dystonia, followed by dyskinesia. In terms of non-motor symptoms, the major ones you'll see here, so anxiety was the number 1, insomnia, fatigue, excessive sweating, depression, anxiety, as I mentioned there. So also then we asked, did your symptoms worsen the week before your period? Because that seemed to be something that people were saying in the community. And yes, again, a very large 84% said their symptoms were worse the week before their bleed, but also that there was almost 50% said it still continued on during their bleed, and then for some, a smaller percentage after. So just showing you here in terms of the cycles that generally, as I say, 86% before their bleed and about 50% sort of later on during their bleed. And then we asked, is their symptom control difficult during menopause, perimenopause? And again, just over 60% said yes, they noticed that symptom control of their Parkinson's was difficult during that sort of change. Were your symptoms worse or better postmenopausally? And they were about the same. For 20% said that they were worse. Now, the number of people who answered this were quite small in terms of, I had 209 women answered, but there was probably only about 30 odd that were menopausal, postmenopausal. So we need kind of a further survey to kind of get more robust answers around that. Did you have hormone replacement therapy? So a large number said no. So, you know, quite amazing that there was, you know, such a large proportion who didn't have hormone replacement therapy. Did HRT for those, and again, the numbers were relatively small, improve your Parkinson's symptoms? So just over 40% said yes, and then about the same and worse were just under the 30%. And I suppose it just speaks to the point of it's individual in terms of how one responds. But again, we need larger studies to look more into this, because if HRT is shown to be beneficial, we should be, you know, informed of that. And the research that they're doing a lot on neurodegenerative conditions, particularly in Alzheimer's at the moment. So through the Women's Alzheimer's Project in the States, they're doing a lot of research, and they're showing that there is potential benefit to reduce the risk of developing Alzheimer's by taking HRT, and also Parkinson's, but also that there may be signals that it could help in terms of progression, but we need much more robust evidence to say that. So then we asked, when did you start HRT? So most of them started during perimenopause, and 22% after. And the research again would show that there's a kind of critical window of kind of a 5 sort of years after you kind of start going into that menopause state. That's the time, the critical window to take the HRT to help impact potentially risk of things like Alzheimer's and Parkinson's. And the question is that also the case in terms of potentially slowing progression? So these are questions that really are really important for us as women living with Parkinson's. This was a really astounding fact that came up, and there's the way here. How did neurologists engage around hormonal effects on Parkinson's? So basically, did the neurologist, tell you about the impact of hormones on Parkinson's symptoms? Basically, almost 90% said no. Did they adjust your medication around your cycles if you were still menstruating? 94% said no. Did any of your neurologists suggest HRT? 94% said no. And did the neurologist discuss with you the effects of perimenopause and menopause on your Parkinson's? And again, a whopping 90% said no. So, there really is a large lack of awareness around these issues. So basically, we are not small men. And from the survey I did, we ran 2 webinars with the Cure Parkinson's Trust in the UK and PMD Alliance in the US, where we had panels of experts on and women with Parkinson's. And really, it showed that there were a lot of unmet needs of women living with Parkinson's. So actually, subsequent to those webinars, myself and 2 other women with Parkinson's, one is a doctor and two are doctors, one is a gynecologist, and myself co-authored a paper with 3 of the experts that were on the webinars with us. And it looks into all aspects of gaps. So I'm just going to kind of go through a few of them. Key interventions in terms of women with Parkinson's have higher levels of osteoporosis, and that is in comparison to the controls without Parkinson's, and also in comparison to men. We have a higher fracture risk, and also in terms of weight, we lose weight more early in the disease than men with Parkinson's do. So really, women should be screened for osteopenia or osteoporosis on diagnosis, and they should be really referred to a dietitian and physio to basically help prevent malnutrition and bone deterioration, because weight loss is and sort of low body weight is associated with worse outcomes in Parkinson's. So we want to get on top of that early, and we know from research we've done in the Parkinson's Association that neurologists and GPs are not weighing people with Parkinson's. So women with Parkinson's also have, as Lisa mentioned, a higher incidence of pelvic floor disorders. So they should be screened from it, and referral, as Lisa mentioned, to help with the pelvic floor. In terms of motor symptoms, women and men differ. So women tend to have more tremor dominant Parkinson's. They also suffer from restless legs, facial masking, and more dyskinesia. Women tend to have more problems sleeping, more mood problems, and urinary incontinence that was mentioned. Women also tend to have more mood disturbances, anxiety, depression, apathy, and feelings of worthlessness, self-punishment, loss of pleasure, and self-dislike, and present with more sort of emotional impairment and more pain. So in terms of psychosocial differences as well, women tend to have more psychological distress, self-reported disability, a negative self-image, feel a sense of loss of femininity, impaired sexual intimacy, feeling of not been heard by their loved ones and the health professionals. And as a result, women tend to downplay their symptoms. So as this quote says here, although I realize that getting this disease is not my fault, it did compromise my roles as a mother of a young child, the daughter of an elderly parent, a wife, and a business partner. So there's many women out there trying to juggle a lot of things, including their Parkinson's. And on that note, care differences are quite substantial. So women with Parkinson's are twice as likely to have a paid caregiver. And they have many more years where alternative caregiving may need to be arranged because women outlive their spouses. Caregivers attending appointments were lower for women. There's a faster rate of using a paid caregiver than men, and women are more likely to reside in a nursing home, which is not great because access to services for people with Parkinson's in nursing homes, if we think outside of a nursing home is bad, it's even worse in a nursing home. So these are all things that really, as women, in terms of future planning, it is important to kind of be aware and, to be looking into these kind of services. In terms of hormonal stages, obviously, as I mentioned, in terms of the menses, sort of PMS and our Parkinson's symptoms worse, maybe up to 2 weeks out of every month. And if you think if a woman is diagnosed in her 30s or 20s, as we know some women are, and they can live with it for a long time, that is a substantial amount of disability. And actually, we know from research that people who are diagnosed in young onset with Parkinson's tend to lose 20 years of employment life, and also if you're diagnosed mid-employment, that you lose up to 10 years. In terms of pregnancy, obviously there's big issues around, giving advice around fertility planning, safety during pregnancy, childbirth and postpartum. So there's a lack of research around what medications you can take. And I know from talking to women that some women have basically put off having another child because their neurologist is not up to speed with the medication implications. Obviously, in terms of perimenopause, we need to have a look at research into HRT and managing the symptoms, and also pelvic floor and the osteoporosis issues. Also, in terms of research, women are less likely to be referred to centres of excellence. That's particularly in the US, but generally in Ireland we have a lack of access to research because we don't have a patient registry, and we're very much underrepresented in clinical trials, which means that the trials are giving outcomes on the basis of men, not women, and obviously, as we've seen through the two talks tonight, we're quite different. So we need recommended guidance that is needed, is specific guidelines on the use of hormones, customized dopamine replacement dosing around fluctuations, say with regard to the menstrual cycle, personalized self-care strategies taking into account women's specific symptom needs. So for example, things like dyskinesia are more prevalent in women than men. And so dopamine needs to be adjusted accordingly. We need more tools to help track and convey unique symptoms, and basically also psychological and social supports. And women can use symptom diaries, as Lisa mentioned, to help look at their hormonal cycle tracking, and also maybe look at other things like the dyskinesia and what's, maybe what's going on in your life that maybe is worsening that in terms of your meds or what activity you're doing, etc. So just on that note, I suppose I'm going to do a little plug here. Because of this whole journey I've been on, I took part in a hackathon back in the end of last year as a patient champion for Parkinson's, and basically this is where people come together to help develop kind of digital tools to help people with different conditions. And I put forward the idea of being able to track Parkinson's symptoms around the menstrual cycle. We won the hackathon, and since February I've been working on developing a digital health app, but it's not just going to be focused at women who are still menstruating, but women across the different stages of life, to help people be able to track their symptoms alongside their medication, to see, what trends they might notice, when they might notice if they exercise, does it improve their symptoms? If they have to change their medication, does that improve their symptoms or make things worse? And the idea is that you'll be able to then show it to your neurologist so that you can actually, have the proof that, your symptoms did get worse, prior to your menstrual bleed. And so it'll allow the neurologist then to treat you accordingly. As Lisa mentioned, we do know some women are getting extra medication. Some women are staying on the oral contraceptive pill without a bleed week, and that is helping with their symptoms. So obviously it's only anecdotal at the moment that people are getting treated in different ways. And what we want to do is to develop research evidence to show that this is actually a real thing that's happening, and similarly around the menopause in terms of people transitioning, and similarly around, say, dyskinesia, being able to prove that women are having more issues in relation to this. And say in an app like this, we know with dyskinesia, if you exercise, it can actually help dyskinesia. That's what some of the research is showing, but we need ways to be able to track and prove this. So in terms of a gender-specific approach, we need people with women with Parkinson's to tune into your PMS, your perimenopause, and your menopause symptoms and their impact on your Parkinson's symptoms, and track your symptoms over a 3-month time period so that you can see a pattern, whether it's there or not. And you can discuss that then with your neurologist and your Parkinson's nurse. And then you can actually have evidence of which you can discuss medication options and adjusting them. And then you'll be able to see whether it actually makes a difference or not if you can track during that change. Also, it's important that you look for advice on stress reducing therapies such as exercise and meditation for women, particularly in terms around those anxiety in particular times around hormonal stresses. Taking part in research is really important for us as women, because that'll help to change the dialogue, because as Lisa mentioned, it's very much said that that it's an older man's disease and it's just about a tremor. We know it's not that. 40% of the people living with Parkinson's around the world are women, and 20% of people around the world living with Parkinson's are under the age of 60. So we need to change the dialogue. And the only way we can do that is actually taking part in research and also standing up for ourselves. And the other thing that's really important in terms of for women is to find your tribe. And I found my tribe when I went to the World Parkinson's Congress in Kyoto in 2019, 2 years after I was diagnosed. And the next one is coming up in Barcelona next year. And I'd really encourage many women to attend. We're actually going to have a whole section focusing on women and their needs. And you can meet I met loads of people around the world who are friends now. And you learn a lot from each other. It's really motivating and empowering. The other thing then, since the World Parkinson's Congress in Kyoto, myself and two of my close friends now set up just a website to raise the voices of women with Parkinson's disease. And also I did a fundraiser called the Dopamine Dunk, along with a number of other young onset people who went to Kyoto in 2019. We got together and said we'd raise funds to have grants to send other people with young onset around the world to the next Congress. And we've raised over 80,000 euros. So those grants will be available for people to apply for. I think it's the beginning of next year. So there's various kind of links there in terms of the different webinars that we ran with the different experts. And just say to you that if you'd like to register on the My Matter website, in terms of being able to get on the wait list for the app and to get a chance to test it out. And there's also a free book on how to manage food cravings, because this actually came up as a really big topic time and time again with many women with Parkinson's around hormone fluctuations. So that's me. Stop and share.